I'm really pleased to welcome you to today's conference on improving decision-making in international health financing. This conference is near the final stage of a project that we've been working on over the past 18 months or so, which looks at the challenge of financing global health priorities. And when we were first thinking about it back in autumn 2021, as the pandemic was progressing, it was very clear that the international community should do everything possible to prevent a recurrence of what we had just seen. And this was not just because of the loss of life and human suffering that the pandemic had caused, but it was also because of the vast economic costs. And this could be seen in the leap in public spending in advanced countries. I haven't looked at the latest figure, but certainly in the course of the pandemic, it got up to $16 trillion spent in total through various public spending routes. And in addition, we saw the rise in debt distress in low-income and emerging economies. And some 60% of low-income countries are either in debt distress or at high risk of debt distress. And the pandemic played a significant role in that. And there's also a considerable negative economic legacy, which frankly we're still trying to comprehend. The loss of human capital caused by keeping kids out of schools for many months in both rich and developing countries. And also the long-term effects, not only of long COVID, but also of the disrupted health systems, which is a very acute issue in the UK at the moment, but I think in other countries as well. But despite a great deal of analysis and the reports of highly distinguished commissions that have told us, in a sense, what we need to do to minimize the risk of future pandemics, but also the relatively modest amounts of money that it would cost. Actually raising this funding and sustaining it is proving much harder, certainly than I would ever have expected. So our project sought to focus on the reasons why this was the case in political economy sense, not just for the pandemic, but for other global health catastrophes as well, where, again, the economic, the humanitarian, and other cases are very strong, and yet the funding doesn't follow. And also what might be done to address it. And so we're really grateful to the Bill and Melinda Gates Foundation for their financial support in helping us undertake this work. Now, the project has included a number of private and public roundtables, and a number of people here very kindly took part in these, so thank you very much for that. But we've also produced 2 case studies looking at the historic experience of raising international finance. One of these looks at HIV and is being published today. The other looks at AMR and will be published very shortly. But what our work pointed to overall was that there was an urgent need for all those involved in decision-making on international financing of global health to agree and apply, as far as possible, a shared set of criteria as to how these decisions should be made. Now, we recognize this is politically very difficult, particularly in the space, the health space, but particularly in the context of weak global governance. But it is the one thing that we felt would make a fundamental difference to the perverse outcomes that we see today. We also concluded that this approach could be supported by some relatively modest institutional innovations in the global health architecture. Now, we've captured these ideas in a paper. However, we were keen not to preempt the discussions today, which I'm sure will provide very valuable insights on this whole set of issues. And so what we decided to do is provide you with some more detail on our emerging findings in the final session of the conference today, but then to incorporate everything we'd heard today together with where we'd reached in our work in a final version that we would publish shortly afterwards. I think we are going to have some really fascinating panel sessions, and inevitably there'll be a lot of focus on answering specific questions. Views are going to come out on exactly what the rationale for global health spending should be, how it should be organized institutionally, and so on. But I just emphasize we're very keen to maintain a focus also on the decision-making process itself for these questions and how that can be improved. So it's not so much what the answer is, although I'm sure there will be a lot of discussion about the answer, but it's also how do you get to the right answer.
we've seen a big difference in terms of access to health products compared to the early 2000s, medicines, vaccines, and major innovations at the horizon. The ODA funding to global health grew strongly from $7 billion in 2000 to $27 billion in 2020. But I think we are also all very much aware of the dramatically changing environment, the geopolitical tensions, new alliances, and nationalistic developments that make our collective work harder. We have over 330 million people living in humanitarian crises and migration, and these emergencies, keep many of us in worry and busy. The climate crisis is very much already a health crisis now and affects already stressed regions and countries, putting a lot of new pressures and shifts in burden of diseases, both on the NCD side as well as on the infectious disease side. And, perhaps also as a result of this, many of us put some fundamentals of global health models into question. We're clearly off track when it comes to the SDGs, when it comes to our health goals. We've not achieved the increase in financial protection or UHC goals. And we still live in many countries with relatively weak systems that are far from shock resistant. The domestic funding in many countries remains low and is even going down to health. And we have a perceived dominance of the global north when it comes especially to finding solutions. The governance of the global health landscape is perceived as fragmented, and we have no clear vision today on with regard to transition or sustainability. But I do think the wider discussions between health and finance, have really triggered a lot of rethinking. Of course, the ongoing negotiations on the pandemic agreement, but also any future medical countermeasures platform take a lot of this into account. And, last not least, of course, the Chatham House event today, I think, can really bring us, some perspective, new perspective and recommendations forward. So, with this, my last slide, I discussed with Jon Leiden, Christina Schrade, and others. Next slide, please. Sort of what are sort of the questions that we would love to discuss and see addressed in this session. First of all, we rapidly fell back into a panic and neglect mode after COVID. Have we lost the momentum when the global COVID pandemic could have driven increased investments in global health? And why did this never again not move the world to make a dramatic investment in pandemic preparedness? Have we exhausted ODA as a source for global health investment? And what are the alternatives, particularly given that, for example, this new pandemic fund instrument has so far not been able to bring new funding sources to the table? Then the replenishments, where do we go? There's clearly a replenishment fatigue on the one hand. On the other hand, we do see very successful replenishments bringing in amounts as they have never before. Other efforts have been disappointing. So are they still the right way to raise funding, or must we all do them better or differently? And last not least, in this world of inadequate resources, in a situation where several of us have started to let people go, is donor money channeled effectively? Is it channeled to those that shout the loudest? And how should we address prioritization going forward?
So I think, if one is to say there is rationality, then the pandemic prevention, preparedness, and response agenda really is an agenda that kind of lends itself to international investments, because, as was said in the earlier panel, if there ever were a global public good, it's investing in pandemic prevention, preparedness, and response. Of course, climate change as well. And no matter where you invest, an investment made in a developing country benefits all countries. And there's one lesson we learned from the pandemic. I know it's a cliche, but no one is safe until everyone is safe.
To come back to what I was saying, I wanted to actually, one of my concerns has always been, and I am very encouraged to hear some of the efforts being made to change that narrative, is the underrepresentation of certain groups of the global community. Usually the ones are much more defined as the recipients rather than the contributors. And I have issues with that language as well. We can talk about that at coffee time. But and this is actually about how representative are our decision-making bodies in these initiatives and in the institutions of the people where the need is greatest. And I don't mean the typical token African voice on a voice, or in this case on this panel. I actually want to understand how we actually change the architecture, the structure and representation in the technical bodies, groups and committees that determine what then gets to the high-level representation. So it's not, I mean, the G7, when the health ministers and the heads of state meet, then that's not where the work's done. The work's done beforehand in those little groups, those working groups that actually shape the issue, gather the information, and then present it in a way that the political and economic conversation then follows. Where are those voices? The low middle income countries, the predominantly African voices are not in those spaces. So you end up, like I said earlier today, depending on where you start, how you frame the issue and the question, that drives your direction. And so we've got to start to think about how we ensure that the voices, there's equitable representation of both those with current power and those who are often the recipients of that generosity.
The point I want to make is that whether this cycle of replenishments is sustainable. And from my bureaucratic point of view, who is always asking money from the foreign, finance ministry and the parliamentarians, it is becoming more and more difficult. And of course, during the pandemic, there are some, of course, the political attention was higher. And as everyone is discussing, so that, the mode has been changed. And then as someone else also asked, there are other important issues like food security, climate change, security issues. And so we really need to devise a different model. And I was hearing the panel, I was a bit more encouraged that there are many things happening in that direction. But I think we need to really think about how to do differently, including the replenishment model. And one area that might be interesting to look into is the maybe we need to have more coherent board mechanisms. There are different boards in Global Fund, Gavi, and everything. But for example, in New York, funds and programs, UNICEF, UNFPA, they are doing this joint mega board. It's a preliminary kind of exploratory mode. But maybe we could think similar things about the global health initiatives. These are great initiatives, but we need more alignment.
And yet we didn't really have a good sort of overarching picture of where those biggest risks were and how to mitigate them. And I think in the wake of that, particularly, that's a really big part of the work plan. And so we're doing some work in terms of trying to build a sort of model understanding of what that picture looks like, bringing together indicators of sort of health, but also, debt ceiling, et cetera, fiscal strength, and trying to understand what those transmission mechanisms are. And I think that's quite new. And I think the really key thing about that is that it then kind of translates into language for finance ministers, because it's the link to the global economy. But it's a much more, I guess, detailed, sophisticated link than, we know the cost-benefit analysis is really strong. but it needs to be articulated and understood in a more detailed manner. And so that's the aim of that piece of work. Finance and health ministries at domestic level, for them to determine their own priorities, right, within each country, for there to be, what needs to be happening at the multilateral level and on a global level. So the idea of much of the work is not to say X money should go here or there, but to link the underlying sort of analysis and evidence that we have with the sort of political, I think the vertical sort of leading up to the political decision makers, and trying to translate that into language that is universally understood across finance and health.
So embedding professional organizations and civil society and mandate them in the implementation of national action plans, I think, is a very cost-effective way of working from the government side. So during the many years of work in LMICs, reactors gained significant insights on the barriers that these countries face to address AMR, and we tried out with our limited resources to support a few of these countries over time. The challenges that these countries face are raising. The race is including the generally limited political understanding, the support, data gaps, difficulties with cost evaluation and prioritization. I mean, AMR is technical, it's multi-sectorial, it's complex, and it's very, very often still neglected. And we don't see so many champions and politicians engaged in this from the countries in the south.
How are you bringing authentic lived experience to the table? I say this because, one of the things that concerned me recently at the high-level meeting again in New York was that I was in a room where there was a couple of people who'd been brought in as CSO representatives, but I was most disturbed to see them in the corridors being rehearsed, their lines who had been written for them by somebody else from the sort of the mothership, as it were, that is based either in New York or DC or London or wherever it was. So the mothership has given this, nice brown or black or whatever person that they've brought from somewhere else in the world, and they've given them lines to speak. They're rehearsing them. So in many ways, is that the true voice from the low and low middle income countries? Surely the true voice is the person who's able to speak, whether they can speak in the dulcet tones of our late Queen Elizabeth or not. They are at least able to bring forward their voice to the table.
Certainly in terms of Pandemic Action Network, something that I personally believe very passionately in is this notion of networked advocacy. I don't think you can build monolithic global campaigns because it will always skew towards the global north, the kind of big organizations. I actually think that, so for those that don't know, I found a few like-minded people who were, by the way, ahead of me. I was getting a bit irate in March of 2020 as a Brit living in Belgium, seeing what the UK government was doing, seeing what the Belgian government was doing, very different responses. I was thinking no one seems to have a clue what's going on. I'm not an expert on this issue, but I know a bit about corralling people. So maybe I can find some experts to help. And then I found some people who were like, actually, we wanted for a long time to set something up on pandemic prevention and preparedness. And we decided to say, right, can we do something useful during the COVID response and also pandemic prevention and preparedness? Now, in terms of me as a white woman growing up in the UK, living in Brussels, of course, there's legitimacy that I have and very much legitimacy that I don't have. And I think, so one of the things that I did when I came in as exec director last August, the first thing I did was to hire an Africa director and to also give policy sign-off there. So that's not tokenistic. It's like, look, we're not the people to decide and say, we think this is best for you. Please tell us what that should be. In terms of how we operate, this networked approach is crucial. We have about 80 partners on the continent of Africa Now, within that, there's the more sort of bigger CSOs. There are community groups as well. We can always do better, I think, at making sure those community voices come through. But I think the way that global organizations who might be headed in the north set themselves up you need to be really careful about how you do that and self-conscious about how to do that. That said, when it comes to financing in particular, there's a heck of a job to do for advocates based in high-income countries, not just because that's where some of the ODA money or other money is. It's also the place we need to advocate to stop a lot of the bad stuff happening. And I think when it comes to health financing or any financing, we know what we want to raise money for. We want to have a fully capitalized pandemic fund. We want to have UHC. We want to stop illicit flows. We want to maximize DRM. We want all of those things to happen. But we're also naive if we only focus on the raising of the money. We have to be really honest about what rules of the road we can change so that rich countries don't actually get away with things that make it a lot harder to do that.
Finance ministers need to understand that these guys not always just ask for the money for the sake of it, but that the money actually has an impact. And once they see the impact and you show that story, they are actually receptive. I mean, we are at the geopolitical turning point, right? I mean, a few years ago, just before the pandemic, we had, of course, many crises still going on. But now we have a war. We have a scarcity of supply chains. We have an energy crisis. We have food security crisis, biodiversity losses, climate change. So every basically challenge is interlinked. And now when you knock on the doors of health and finance ministers, just yesterday, Germany published the new budget for next year. The finance minister clearly said, next year, it will be like before the pandemic, the budgeting. So there is not much of a money for ODA funding and all of that anymore. And the Western world has in a way woken up that the classic ODA model and giving money to the big players and doing all these replenishments is passé. Because there's a strengthening happening in the global south. They want to own their own health agendas, they want to do investments, and now when you go to these G7 governments and sit at their table, they tell you, so can you tell us, how can we do a new partnership model where we are not only giving money to, let's say, Kenya for a specific health project, but what is, number one, the impact of China on these countries? Because 40% of the world's debt is loaned by China, that's a reality. And all the other G7 and G20 presidencies coming up have a bit of an allegiance to these countries, so let's not forget that in the G7. And lastly, they're asking you now, all these governments, how can we build a new financing model where we bring the multilateral development banks in the middle to de-risk investment, get basically investments from the private sector in and create partnerships within a country so that we support a project concretely, but not just giving ODA for the sake of it. So they want to turn it into an economic cooperation argument. So the G7 has woken up that it's not charity, it is actually an economic cooperation. So that's the new era we're talking about.
Who we work with as well. When we talk about parliamentarians, I think there are other advocacy strategies that all of us could use in the room. The first one is not only working with parliamentarians, but with parliaments. Because there's this question of the political cycle, and every 5 years or every 4 years, you have to start the work again. You don't have to start the work again with the advisors or the clerks that work in the committees, because they stay for so long, and they are your link. They are your historical link, but they're your link also networking link, I would say. And the other thing that we do also at Unite is that we work with former members of parliament, which I think is really key, because they don't disappear when they go out of office. They're still here. They usually still belong to the party. They still have the same connections. They still have the same knowledge that you gave to them for so many years. You have invested in one person, and then you would just drop it because this person doesn't sit at parliament anymore. So they still have the connection. Sometimes they mentor other parliamentarians. So they could just,
give the work to them. So
Thanks,
this,
Ellen.
yeah, sorry.
No.
So the former members of parliament are key, and I would love to see more organizations working with former members of parliament as well.
Something quickly about the social media angle, which is a new feature, relatively new feature of the international health agenda over the last few years, is this new idea of actually having to work against nefarious forces, not just raising money for the things that we all agree on. So we saw that with misinformation around vaccines. We also have seen it around the pandemic accord, no less. And so these are new realities we have to deal with, which shows the importance not only of being right, and the final thought I just want to leave you with is we don't win because we're right, because we wouldn't need to be here talking about it. We win because we get organized. And that means making sure we know what to ask for from the communities and the grassroots, and that the people all around the world are asking for the right things. That's important. But the other piece is the infrastructure, the campaigns, the advocacy, the ongoing work year in, year out, not just during a crisis. So let's get organized, let's do networked advocacy together, and let's definitely win.
The major issue that we're trying to address here is equity. Equitable access to key products. And the areas where we've seen the most progress is in areas where either you see donors heavily engaging in, so in the big three diseases, HIV, malaria, TB, or when there's already a paying market available, when it's truly a global pandemic, where you do see there's enough of a pharmaceutical industry response. So I would say that the area that we need to see a lot of action in is to prioritize the areas where the problems actually are. So whether they be vaccines for infectious diseases, or when you're talking about new cancer drugs, or when you're talking about older drugs that are being dropped with fewer producers and you're seeing severe shortages worldwide, you need to see more investments in the biggest priorities, and you want to support strong collaborations, but you want to see that the support actually goes towards mechanisms that work. So at the end of it, you want to see less of the vertical approaches, more system-wide approaches. We in fact hosted an event recently where we actually identified a number of key actions which matter today for regulators, for procurers. How does financing actions come in? But the end goal is to recognize that you have to understand the fragmentation and the interdependency of the supplies and the raw materials that are there, and address these severe shortages. So in our work, we've seen that at the end of it, it's always when it comes to market and donor-supported mechanisms where you have more chance of engagement and results. And when you don't have that, you get very well-meaning company executives that might do a few smaller programs, but they either don't last long, or you don't achieve necessarily the scale because it costs a lot of money and you don't necessarily have partners who have the ability to pay. We've also seen some companies raise funds via bonds when there's a recognition of the problem that they're trying to solve, and we see that with sustainability-linked bonds. But you can also see that some companies are able to pool their finances together in the case of the AMR fund, when they recognize a problem, but they want to contribute to the problem either via money or expertise at the same time. But these are, again, some of the same companies that used to have anti-infective businesses in the past.
The other thing is, and maybe just to bring up something that was briefly mentioned now that was discussed from the diabetes perspective, is that from our position, as I mentioned, from our portfolio, right, the burden of disease, current burden of disease might not be, from NCDs might not be corresponding to the level of investment from global financing. So it's been roughly stagnated around 1% to 2%, while the burden of disease in terms of mortality of NCDs is around 74% of total deaths worldwide. And 85% of deaths occur in low and middle income countries. Those are premature deaths. So there's, as someone mentioned, this is on top. It's not if we need to fix this or that. There's kind of like an overlapping of problems. And so this is on top of current situations that we have, and we see this double burden from infectious and non-infectious diseases.
Are you suggesting the public sector should subsidize, give more grants for NCD research?
Not just NCD research, but also NCD treatment on the entirety of the patient pathway. The pathway of the patients is quite complex. You need to go from early screening or prevention to diagnosis to treatment to post-treatment. So there's plenty of areas where funding is needed. Treatment is just one of them, but getting access to early diagnosis can make a whole difference. Prevention campaigns, understanding that some deaths are avoidable and some deaths are unavoidable. Those type of things are something that needs to be considered.
I think when we talk about private sector engagement, it's worth keeping that in mind. There's lots of useful things for the private sector to do, but they're not going to be the magic source of additional financing that solves all our problems. They are really important actors who have a lot to bring to the table. They have useful sort of tools and roles to contribute. I think there are certain kinds of private sector activities that can be better or worse for access, let's say, and it's great to hear that investors and shareholders are now, putting pressure or sort of interested in facilitating access through their activities. So what is the private sector good at? They're good at moving fast compared, in most cases, to kind of governments, which are, I think, slower to respond. They're good at innovation. They are good at making pretty hard-nosed decisions about making money, about cutting off projects that aren't working or they don't think have a high probability of success, about reallocating funds elsewhere. There is a lot of talent and expertise in the private sector that can be, harnessed for good. And there's a lot of physical infrastructure capacity. There's manufacturing plants, there's laboratories, there's a lot of different resources that can be channeled. So I think it's useful to think about the private sector as a partner, but I think it's a mistake maybe to think about it as the answer to financing problems. They are a partner to help use financing well and to engage in maybe stopping some of the more harmful practices that might be out there. But I think in terms of generating finance, I'll take every bit we can get, so not saying no to anything, but I think we need to be realistic about kind of what the role will be there.
6 slides altogether, so we're going quite well. I wanted just to say a little bit about how we had narrowed down the area we were trying to address. There are 3 respects in the sense in which we did that. Firstly, global health as a whole has an enormous range of activities, objectives, funding sources, and delivery organizations. What we sought to do is that some of these you can group as being determined and driven at the domestic level. Some of these you can group as being determined and driven at the international level. Both are important, but our focus is very much on what is determined, driven at the international level. We also, as I mentioned earlier, decided to focus in on the public international finance role. That doesn't mean to say that the private sector philanthropy is not important, because clearly they influence what the public sector does, and also to some degree what the public sector does is jointly determined with what the private sector and the philanthropy does. And another thing which I've not put on this slide, but I think is very important, that we are trying to find something that is kind of relevant in the short term, the next 2 to 3 years. There are clearly things that are very important over the longer term, particularly around the reform of the international architecture, and nothing in what we've said makes that a less important mission and objective. But we're just conscious that that and a number of other things is going to take a long time to fix. So we were trying to look for things that were relevant in the short term. So with that, I'll hand over to Emma for where we came out.
Thanks. So next slide, please. So we came to a conclusion. This framework is made up of 3 main recommendations, and that is, the first one is the area of a shared criteria. So that's really trying to come to some all key decision makers and influencers. So there's going to be a load of factors that are used to determine whether to support a particular global health activity through international public finance, and if so, to what extent and through what international mechanism. But these factors can be organized under 5 main questions, which you see there, and that is the rationale for intervention, and that's our first session, which was the motivation. So why, why would you want to use international money for this? And there may be several cases for international financing, but we found that at least there were 3 main overlapping rationales that need to be considered at both the national and the international levels. And the national impact may be direct or indirect, so resulting from improvements at the international level. And those are the things we discussed of humanitarian, how many lives can be saved, the public health argument. How many lives can be saved, how much suffering can be alleviated, is there a widely accepted moral and or rights-based case for intervention that complements these factors. On the economic, we've discussed that a lot too, which is the economic benefit of this, and that runs from everything with will economic productivity and or national output be higher if you fund this relative to what would otherwise have happened, and over what period? How will it affect public finances and private incomes? What will be the effect on income inequality and longer-term economic resilience and stability? So what's the opportunity cost of the funding? That's also another economic consideration, i.e. what other activities would have to be foregone if you take this route. Then we've heard a lot about the security arguments. Will it contribute to a reduction in migration pressures or political stability or influence geopolitical alliances? Will it improve the effectiveness and or protect a country's armed forces? Will it help improve resilience to terrorist attacks or improve global biosecurity? These are all real considerations that go into whether this stuff gets, what is the rationale for funding? And can it help reinforce support for democratic political institutions? So once you've assessed these criteria, so this is what we're thinking are the factors that everyone should try to come to some agreement of these factors going into assessing whether a certain proposal qualifies. And then there are 2 cross-cutting issues. One is complementarity. So do these factors point in the same direction, or are there trade-offs? And in the latter case, how can they be resolved? And then also there's the whole issue, which we've talked about quite a bit, which is the uncertainty. So how much uncertainty surrounds the answers to the questions? How easy will it be to reduce the uncertainties through additional research or other methods? And to the extent that uncertainties can't be resolved in the necessary timescale, how should the precautionary principle be applied in these circumstances? And that cuts across all those different factors. So the next bit is once you've decided that you should public international finance be deployed? Are we still on the same? Yes, we're still on the same thing.
So should it be public, basically?
Should it be public rather than domestic or philanthropic? So I think we've gone over that quite a lot. And the key considerations that came up for us in our work is how well understood is the case for intervention on this issue among governments and the wider public, and to the extent that it's not well understood in either respect, how likely are national authorities to underprovide. So if you think it's going to be underprovided if you don't have this, that is a consideration. And also equally, are the benefits from the activity a public good, leading to provision if public international finance is not used? Does it contribute to the achievement of internationally agreed goals or targets? We've got the SDGs or any other international commitments. That's another consideration for should public international financing going to be a good idea. But also you've got, is it more efficiently provided collectively by a number of countries pooling their efforts in a single institution, either because of economies of scale or scope, or because an appropriate international infrastructure for its delivery already exists or is needed. So is public international finance the best way to ensure equitable access? That's another consideration when thinking about should public international finance be deployed. So the next one we go on to is how should the required financing be delivered? That's really the institutional piece. So as we've said, it's already highly complex. And there's potentially much to be gained from reforming and simplifying. But in the meantime, there's a couple of steps we think are necessary that are key characteristics of the issue to be addressed. And that is the required intervention already being undertaken to a partial extent by existing international organizations and national authorities, so that the need is for greater prioritization or consistency? Or is the need for a fundamentally new response, i.e. in terms of development of new treatments? Does the issue require a one-off intervention, or is it more a trundling along longer term, sustained indefinitely? That's another consideration for how it should be delivered, through what channel. And then another consideration to decide what channels to put it through is, does the intervention have the characteristics of an investment, insofar as public or private income will be increased if it's successful? And if so, can some of this income be captured by the public sector to repay the capital committed? Another consideration is, does the intervention require collaboration across many different parts of the public sector, as in AMR, and with other sectors? And then lastly, how easy is it to monitor the effectiveness of the intervention once you've done it, to validate the underlying case? So after you've done that, the second step is to develop an institutional response that takes those characteristics into account. The next piece of this is what is needed from political leaders, civil society, philanthropy, and internal public sector champions. That is really about the last bit in the afternoon, where we talked about the advocacy piece. How do they fit into the picture? That is consideration when you're evaluating a certain intervention that's proposed for international public financing. How does that look? Who do you need to interact at what level? Equally, the private sector. So next slide. I haven't gone too much into detail of that because I think we went through a lot of it. Okay, so once we get a bit more comfortable with this set of criteria, obviously it's not efficient to put every single proposal to the test with that. It's going to take too long. It's necessarily resource intensive and requires time to complete in each individual case, particularly if it's to be carried out with effective participation and engagement across all key stakeholders. So therefore, we think it's only makes sense to implement it in full for major decisions which should have a lasting impact. And then as decisions are made using this process, as it builds up, it should lead to the development of a core set of global health priorities. So that's really about a common understanding of what constitutes core international health. And that, for us, was a bit of weasel language, so we don't have to say global public goods. But you know what we're talking about, because we're not going down the global public goods route of non-rivalrous, non-exclusive. So we're talking about, as you use this framework and use the criteria to assess it, hopefully what kind of naturally falls out of it is some kind of common understanding of what's in and what's out. What's in the bucket, where that it's to be paid for by public international finance, and what's really not in the bucket. And I think that's probably going to be a very politically challenging stage of this. And I think that will kind of emerge gradually. But our last recommendation, move the slide please, and don't have a fit, but it is, and there's a good reason, and Creon will help me out here because I need a bit of moral support on this, is that we think, we're not big fans of adding to the complexity of the infrastructure, but we're not talking about a new initiative that's going to be demanding funding. through a replenishment model. We're talking about the fact, yes, there are places in the architecture, WHO for one, there are others like the Institute for Health Metrics and Evaluation that provide the analysis and the data for this, but there actually is, unlike for climate change, which has the IPCC, which is a trusted, universally accepted, that's what underpins this. They don't do costly research, they recruit experts, but that is the place that we all go to draw on to make the decisions in climate change, and it is universally trusted and independent. And we're not saying that it needs to be a new piece of the architecture in there. It could be folded in, and that's another political decision of should it be taken on by WHO, be in the secretariat, be inside WHO, outside. That's really for the key stakeholders to decide. But we do feel that there is a need that would facilitate better decision making if there was a commonly trusted institution or organization or body that can provide the independent data and analysis that underpins it, that can evaluate what's the burden, what's the problem, and also are the interventions effective, and is the money that's been deployed doing any good? So that's really our three bits to this, and we just wanted to put that out. I guess really not. We were hoping it won't be ripped to shreds, but, that's why we didn't want to introduce it at the beginning, so we didn't want to prejudice all those great discussions we had to try and get people to talk to that. But now we would actually like some kind of discussion on that, as well as other ideas. Yeah. So I'll hand back to
very much
now.
so. I mean, so Emma, thank you. You had the most difficult bit to do. I probably would just add one bit, which to some extent reflects the discussions we've had today. An awful lot of the discussion was about the within health choices. Should it be for... But, coming at this from outside health, and, you could see this reflected in some of the questions I asked during the day. And an equally important thing is how do you choose between health and other things that you have to do?
That's the first step.
And the evaluation criteria are designed to get at that. These are criteria which actually bring in what other people also think is important, to bring those evaluation criteria together so that then you're placing health in the context of the other things that finance ministries need to finance. Now, I am confident, partly because of all the things I said at the start, that health would probably do very well when it is placed in that context. And I think a lot of what Serena was saying was actually, very important for this, because she's saying actually you need to package the health argument in a way that can be compared with other things that need to be done.